Hello everyone, how are you? I think you are fit and fine with your family. So today I will discuss with you about pediatric surgery, and this is my first class in pediatric surgery. And I think previously two classes have taken by Dr. Faisal, and I think you all are present at that class. Okay, now I'll share with you and discuss with neonatal intestinal obstruction today. I am Dr. Mohammed Abdul Momin, Associate Professor, Pediatric Surgery. So I think you all are present and also hearing. So now, first, little bit discussion about history of pediatric surgery, and I think you are uh, all are clearly showing my uh, slide. That is history of pediatric surgery. It is a subspecialty of surgery involving the surgery of fetus, infants, adolescent, and young adults. Pediatric surgery arose in the middle of 1879 century as surgical care of birth defects required novel techniques and methods. Early 1940s, under surgical leadership of C. Everett Koop at Children's Hospital of Philadelphia, newer technique of endotracheal anesthesia of infants allowed surgical repair of previously unevitable birth defects. By late 19th century, the infant death rate from several major congenital malformation syndromes had been reduced to near zero. So in case of our country, it is not uh, early that in 1985 the pediatric surgery has begun in our country, and especially in Dhaka Shishu Hospital and Dhaka Medical College and Sheikh Mujib Medical University, all and some pediatric surgeon at that time taken trainees from different parts of world, and now slowly the pediatric surgery is evolving, and this is age group of pediatric population. You know, from 0 to 28 days we call neonate, and infant 1 month to 1 year, 1 year to 5 year young children, and 5 year to 18-year older children. In our country, we uh, uh, from 5 year to 12 year or 14-year older children are treated with in pediatric age group. And why this age group was done? Due to some physiological and anatomical differentiation from age to age. Uh, this age group is essential and important for all pediatrician and also pediatric surgeon. When you go for anatomy, when you go for physiology, and when you go for any surgical intervention, this age group is important. That is, the neonate is quite different from infant, children, older children. Also, the children is different, and the anatomy, physiological system is also quite different from adult one. So everybody should know about the pediatric age group. And some diseases are more common in case of neonate, which is not common in infant and young children and older children. So remember this age group. You can write it. And physiology of newborn. We know the preterm, term, that is below 37 weeks is preterm, and term from 37 to 42 weeks. Weight below 10 percentile for age considered small group of age. Special problem with preterm infant. Special problem with preterm infant. When a infant or neonate come to you, a history of preterm, low birth weight, these groups of neonate have some problem. Weak sucking reflex is very much weak. You can't suck well, and you know when can't suck well, they did not go get enough mother's milk, and due to dehydration, due to low diet, they can they can't cope with uh, physiology or their life. So, an inadequate gastrointestinal absorption. This is more common for preterm infant. The gastrointestinal system is not well developed in case of premature preterm uh, neonate. That's why the functional capacity of gastrointestinal tract can't not matured enough, and the absorptive capacity, the secretion, and the propulsion, propagative movement of the gastrointestinal tract is hampered, and that's why some gastrointestinal problem may be arise. Intraventricular hemorrhage, hyaline membrane disease, hypothermia, and some cardiac abnormality, that is patent ductus arteriosus, and some apneic uh, problem, hyperbilirubinemia, that is the liver is not well matured at that time in case of preterm infant. So these are some special problem you always look for when you go for examination of neonate, especially. These are some specific physiologic problems. That is glucose metabolism. Glucose metabolism is that is I previously mentioned that the metabolic organ, that is the liver, is not matured enough to metabolite the all types of glucose, fats, protein, and also other things. So glucose is important for fetus at the time of birth. That is, fetus maintain a blood glucose value 70% to 80% of maternal value by facilitated diffusion across placenta. So little gluconeogenesis occur as liver is not will function and depend on glycolysis until exogenous glucose is supplied. After delivery, the neonate depletes hepatic glucose stored within 2 to 3 hours. So these are all conjugates with glucose metabolism, and this may create problem in neonate. And some clinical sign of hypoglycemia. You all know about hypoglycemia when glucose proportion of glucose or amount of glucose is reduced in blood. What are the clinical signs you must know when you go for taking care of your neck? These are weak or high-pitched cry, cyanosis, apnea, apathy, jitteriness, seizures, abnormal eye movement, temperature instability, hypotonia, and weak suck. These are all are problems in hypoglycemia, arising in hypoglycemia. Treatment is not uh, important, but you should know about how can you treat a patient with hypoglycemia. If glucose below 40 milligram per dl, then it is called hypoglycemic status. After 72 hours, it should be more than 40 milligram per dl. Need frequent glucose estimation, and 10% glucose infusion is usually started. An hourly bolus infusion of 1 to 2 ml per kg of 10% glucose is given in IV. This is important due to if there is hypoglycemia, then at times the convulsion may uh, lead to brain damage in case of neonate. And when there is brain damage, the neonate will grow up with uh, mm, some abnormality, some functional disturbance in brain, and this neonate will not grow up well, and the intellectuality and other things will be diminished. So it is it must look for hypoglycemic status should be evaluated in case of neonate after birth, and should be checked promptly by 10% glucose infusion. This is important. What is the clinical criteria for classification of low birth weight infants? When in neonate will come to you, may come to you with low birth weight, prematurity, preterm. So at that time, the low birth weight should be checked, should be evaluated. How can you uh, characterized or will evaluate low birth weight infants? Some criteria, that is plantar creases, sole in the sole, head hair, air lobule, cartilage, testicular descent, or scrotal change in scrotum. So these are some special criteria. You can see these and you can distinguished or characterized that preterm or term. That is, plantar cases may rare and shallow at the preterm and at the term creases throughout. And hair, what about the hair of head? That is cotton wool quality. It's very uh, soft and like cotton wool quality. And in case of term infant, it is silky. And the cartilage of in earlobe is shapeless in case of preterm, but in case of term, it is rigid. And in testicular descent, about testicular descent, we know in case of preterm, the scrotum will be small, and some problem with descent in testis there are, that is empty scrotum may be found in case of preterm. The testis is descend to the scrotum at the and require time in different time in intrauterine life. When preterm, that is, if a baby delivered or birth in 32 weeks of pregnancy, 34 weeks pregnancy, in that case, testis may not descend to scrotum well, and and testis may be found in the inguinal canal as well as in the abdomen also. That is, testis not descend completely, and that's why this small scrotum. So you should go for examination of scrotum as well, and perineum also. When if there is no anus in this perineum, it is completely uh, preterm uh, fetus. So these are some sort of characteristics or criteria you should evaluate well to differentiate preterm and term baby. So estimation of blood volume. Blood volume is also important in physiological system. If a premature or term infant go for prepared for surgical intervention like laparotomies and others uh, operation. So little loss of blood can threaten life in case of mm, neonate. So how much volume of blood are in the infant's body? So this it can be calculated by 85 to 100 milliliter per kg of weight. Suppose a neonate is 3 kg weight or 2 kg, 2.5 kg weight, can multiply it by 85 or 100. That is, if 3 kg weight, then it may be 380 into 80, that is 240 ml, only 240 ml. Suppose 300, 3 into 100, 300 ml blood within the circulations of infants. So this 300 bar blood volume is very minimum. So if you compare with an adult of 70 kg weight, there is 5 or 6 liters of blood are within the circulation. Uh, so infant have only 300 ml blood within the circulation. So if during laparotomy, during any surgical intervention, if neonate lost 100 ml blood, then it is very alarming and may turn into dangerous condition or lethal condition uh, operatively. So every time during laparotomies or big surgical intervention or in small surgical intervention, we should take the blood aside, baby, that you can transfuse blood as soon as possible during laparotomy. So this is important. And some causes of anemia, that is hemolysis, blood loss, decrease erythrocyte production in case of premature and preterm children. And some clinical features of blood loss are jaundice, pallor, hepatosplenomegaly, cord hemoglobin level less than 10.5, cord bilirubin 4.5 gram. Immediate exchange of transfusion is indicated at that time. Uh, mm, Due to jaundice and pallor, hepatosplenomegaly. These are some important features in case of low premature neonate. And jaundice is an uh, important topic in case of neonate. Can develop early physiological jaundice as well as pathological jaundice, because in early, because the hepatocyte is not well matured, and the hepatocyte bilirubin from hemolysis are conjugated with glucoronic acid and form conjugated bilirubin. This is direct bilirubin. Unconjugated bilirubin interferes with cellular respiration and is toxic to neural cell and neural damage called Kernicterus. So remember this the about liver. The liver hepatocyte is not matured enough to metabolism or metabolites of different things like bilirubin. So in some cases, that is early hyperbilirubinemia, physiological bilirubinemia after 3 days or 72 hours, and it may regress. It may the bilirubin in the serum in the blood may decrease at the time. It is not it is not alarming, but in case of pathological hyperbilirubinemia, like any problem in liver hepatobiliary system, like biliary atresia, that is the bile is not properly channeled to the intestine due to atresia. At that condition, there will be hyperbilirubinemia due to atresia of the common bile duct, hepatobiliary system. So this is pathological. And prolonged hyperbilirubinemia, there is some causes, that is breast milk jaundice, hemolytic disease, hypothyroidism, pyloric stenosis, and some syndrome, Kriegner-Nazar syndrome, extravascular blood, surgical cause, that is, I have mentioned it, biliary atresia. These are some causes of prolonged indirect hyperbilirubinemia. The newborn liver has a metabolic excretory capacity of bilirubin that is not equal to at its task. Even a healthy full-term infants have an elevated unconjugated bilirubin level return to normal at 10th day of life. This is uh, physiological. Thermoregulation is important for newborns because the newborn hypothalamus or the regulatory system of brain is not well matured, well developed, and that's why newborns can't uh, maintain its constant body temperature owing to large surface area, poor thermal regulation capacity by nervous system, and small mass to act as a heat sink. That's why these are some contributing factors that may result to low prematurity, or even in newborns can't maintain constant deep body temperature. So thermal regulation is important. Uh, After when you go for examination of neonate, the neonate should be wrapped with cotton wool, and the surrounding temperature should be increased, and also uh, should be wrapped with cotton wool. That is the regulatory capacity can be maintained by newborns. And also, if you infuse any types of fluid within the body, within the circulation, and this fluid should be warm enough. That's it, within the circulation can't, it may maintain the thermal condition. So every time, even in uh, even in home, even in ward, or in neonatal ward, or in OT complex, the thermal regulation is important, because if newborn affected by low temperature, then some circulatory system, some physiological system will be hampered, and it is a life-threatening condition for newborn. Heat loss may occur from evaporation, newborn in contact with wet surface. So, as soon as possible, remove the wet garments from newborn, and wrap the newborn with cotton wool or other things. Conduction, that is direct skin contact with a cool surface, should be avoided, and air currents blowing over the neonate, uh, and radiation, the neonate radiate heat to cooler surface without contact with it. So the cool environment should be avoided. So these are some process of heat loss, that is evaporation, conduction, convection, and radiation. And these are process of thermoregulation, that is some producing heat by increasing metabolic activity or by shivering like adult, These are not well developed in case of neonate, and brown fat thermogenesis involving thermoregulated feeding, increased metabolic demand, and increased body temperature. These are not need to you. Some incubator temperature is determined by the patient's weight and postnatal weight. And if you fail to maintain thermal regulation in case of neonate, you can use incubator, which is a specially made machines where neonate can be kept and to maintain the body temperature. Fluid electrolytes balance is important for baby, for neonate. That is, at 12 weeks of gestation, fetus's total body water content about 94%. Now, in adult, it is 40% of body weight, but in case of fetus, it is 94% and decreases at the time within the gestational age, that is about 80% to 32 weeks gestation, 78% by term, and further 3 to 5% reduction occurs in first 3 to 5 days of life after birth. So it is 75%, you can say. That is, body temp water continues to decline and reaches adult levels approximately 60% of body weight by 1.5 years of age. So it is it reaches up to adult levels in 1.5 years of age. So at that time, before 1.5 years of age, the body fluid amount is different from adult, and also if there is any loss in fluid and electrolytes, it should be promptly uh, minimized. Otherwise, some dehydration, some problem in renal system will be arise. So these are some renal system function of renal system in case of newborn. Now we'll discuss in fact with congenital anomalies of neonate. These are, you know well, that is some genetic problem may give rise to congenital anomalies in different types, and also some structural abnormality may be occur. Some chromosomal abnormality may be occur. So these are some anomalies. Uh, yeah, the common surgical congenital anomalies. Here I have mentioned and showing you in my slide, and you should remember this because sometimes in your examination, your final examination, professional examination, you may ask some questions like this. That examiner may ask you, name some common surgical congenital anomalies. So from head to bottom, head to toe, that is from nervous system, you can say meningocele, myelomeningocele, encephalocele, hydrocephalus. These are some common congenital anomalies concerning nervous system. So this meningocele, this is a problem in spine, spina bifida. You know, if there is any gap between the vertebra, two sides of vertebra can't fuse, and the spinal canal is open up and may continue with environment, and the meninges is some sorts of nerve roots, even in spinal cord may extravasated outside the spine, and it is called myelomeningocele. And also encephalocele, a variety of spine problem. And hydrocephalus, you know, enlargement of skull due to uh, accumulation of central accumulation of CSF fluid when the CSF fluid circulation is hampered through some channels, that is lateral from lateral ventricles to foramen, through the foramen of Monroe to the third ventricles, through the foramen of Luschka, foramen of mesenteric. These are some channels that maintains the circulation of CSF fluid all through the brain. And if there is any obstruction within the within these channels, that may develop hydrocephalus. Even in case of meningocele or myelomeningocele, sometimes uh, get some baby with hydrocephalus with myelomeningocele. That is, the spinal fluid is not uh, well channeled, and the circulatory problem is notified. That is in case of nervous system abnormality. In case of cardiovascular system, uh, chiefly tetralogy of Fallot's, atrial septal defect, ventricular septal defect. Septal defect is also is very much common in case of uh, pediatric population. That is congenital CBS problem. Also, diaphragmatic hernia, tracheoesophageal fistula, diaphragmatic eventration is very much common. In case of neck region, this is some cystic condition are there, thyroglossal cyst, bronchial cyst. What is the GIT problem? This is our main target today. To give you some introduction about neonatal intestinal obstruction. There are many types of obstruction here I am mentioning, but some are very important and common. That is anorectal malformation, that is ARM. Previously it was called in imperforated anus, that is anus is not present and it is not perforate, and this may gives rise to intestinal obstruction, that is uh, large bowel obstruction as well as small bowel obstruction. Anus is not present, how can unit defecates the meconium early? So when there is not perforate, the anus is not perforate, it is called anorectal malformation. And others causes are Hirschsprung's disease, neonatal enterocolitis, intestinal perforation, meconium ileus, valvulus neonatorum, malrotation of gut, duplication of gut, intestinal atresia, omphalocele, gastroschisis, umbilical hernia. These are some intestinal problem in neonate as well as infant. And some are congenital problems, some are acquired. So most of them are congenital in case of neonate. When neonate is present to you with some problem in obstruction in intestine, this is congenital. And in case of infant, infantile hypertrophic pyloric stenosis, intussusception, congenital bends and narration or some abnormality. In hepatobiliary system, you may see colloidal cyst, the cystic uh, malformation of common bile duct. The common bile duct is wholly a cystic malformation. This is called colloidal cyst. And biliary atresia, I early mentioned that biliary atresia, if the biliary channels, that is intracanalicular channels in within the hepatocyte or hepatic canal, and also uh, hepatic duct, also common bile duct is not well formed and it is called atretic, and when it is atretic it is biliary atresia. And others genitourinary system problem are exostrophy of bladder, congenital hernia hydrocele, undescended testis, hypospadias, epispadias, phimosis, paraphimosis, Wilms tumor, BUJ obstruction, and posterior bulb. You can write it in your book or in your khata. These are some problem. You can write it and later on go through this problem. Some facial deformity, that is cleft lip and palate, is also very much important. It is vast majority of uh, uh, pediatric populations are suffering at that time is with cleft lip and palate. Very uh, sensitive issues, and also limb deformity, that is congenital club foot. These are all problems. If you ask a question about these congenital anomalies, you can say it, you can answer to examiner, that is, these are the common malformation you may got in your practice. So now intestinal obstruction is our topics today's. You know that is what is obstruction. A mechanical blockage arising from a structural abnormality that present a physical barrier to the progression of gut content. Or in a word, in a sentence, that arrest of downward propulsion of intestinal content, arrest of downward propulsion, or mechanical blockage arising from a structural abnormality that present a physical barrier to the progression of gut content. It is important. When any blockage within the intestine or any structural abnormality there, if any blockage is occurred within the lumen of the intestine, that is when the intestinal content cannot go in oral to aboral direction, and the content may stuck within the lumen. There may be hyperperistaltic activities of intestine may try to overcome this obstruction by mechanically, but if failed, then permanent obstruction may be developed. That is, the gut content is not progressed in aboral direction. Ileus. This is a paralytic or functional variety of obstruction. When there is the intestinal muscle is smooth muscle, that it is involuntarily, it may be it relax and contract. When it failed to contract, voluntary reaction may be loss in case of smooth muscle, and smooth muscle contraction will be failed or loss. When smooth muscle is not contracted or failed, then there may be loss of peristalsis. So if peristalsis loss, then obstruction may be developed. So this smooth muscle contraction and relaxation is maintained by some electrolytes, that is potassium is important. Within the cell, the potassium is more, and outside the cell, the potassium is minimum. Just vice versa of sodium in body. So when in cellular, within the cell, potassium is lost, then the cellular activities or cellular contraction, relaxation activities will be failed or will be lost. At that time, the smooth muscle cannot be contracted, cannot be relaxed. So, in case of ileus, when potassium is lost due to different in different condition like chronic diarrhea, vomiting, in case of poor nutritional status, long-standing dietary uh, from starvation or problem in feeding. In that case, potassium can be lost, may be lost, and ileus may be developed. So this is an obstruction which is developed due to potassium loss. This is called paralytic ileus. Others some are partial or complete and simple or strangulated. So mechanical obstruction is further classified according to the speed of onset, the site, the nature, and etiology. The speed of onset is determined whether the obstruction is acute, usually in small bowel, and chronic, as in large bowel, and acute on chronic, which spread from large bowel to involve the small bowel. These are some picture you can see here. The huge abdominal distension, the first slide. There is also a uh, malformation or swelling over the spine, lower back. It's called myelomeningocele, and this the upper in the right third picture may show that is the anal area, the perianal area. There is no any uh, aperture or canal or any anal orifice in the perineum. This is called imperforated anus. You may, this is imperforate anus, but we sometimes called it anorectal malformation because there are some other malformation with this disease. That is, the anus or rectum is not downwardly come fully, and not orifices is not developed. Rather, the rectum is continuous with the urethral or urethra, and there is urethral discharge at the early time. This is called rectourethral fistula. This is another picture show myelomeningocele. There is a the low back area. There is a swelling, the soft swelling over a soft. There is a soft skin, and also it is also discharged, and it is called rupture myelomeningocele. The skin is ruptured, and also the soft covering like meninges is also ruptured. This is also a case. This is congenital anomalies in umbilical area or anterior abdominal area. It's called omphalocele. This is also a case of ARM, that is anorectal malformation. There is no anal orifices in the perineum. This is cleft palate, somehow affected by injury, and later on infection occur. This is hydrocephalus. You can see the engorged vessels over the skull. This is hydrocephalic. Mm, it's also a case of bladder extrophy complex, and this is a huge abdominal distension. Abdominal distension. These are some congenital abnormalities. If you go for congenital swelling, that is thyroglossal cyst, branchial cyst, dermoid cyst, cystic hygroma, myelomeningocele, hydrocele, hemangium, and pelvic tumor. These are all are congenital swelling. Neonatal intestinal obstruction comprises some important diseases we may discuss later on, particular uh, particular topics. That is, intestinal atresia is one of the most common intestinal obstruction in neonate and congenital, anorectal malformation, Hirschsprung's disease, volvulus neonatal with malnutrition, neonatal enterocolitis with intestinal perforation, and other conditions may lead to intestinal obstruction like omphalocele and gastroschisis. These are some important intestinal obstruction. Mm, I will discuss one by one in my upcoming lecture class. You should go through the book about this: the intestinal atresia, ARM, Hirschsprung's disease, bulbous notorium, neonatal with malnutrition, so that you can catch my lecture easily later on. So I have some times to discuss with intestinal atresia. That is, this is congenital, partial, or complete absence of canalization or patency of intestinal lumen. If there is no lumen formation congenitally, this is called intestinal atresia. If there is no lumen, so how the luminal content will propagate to the distal part? So the proximal part will be dilated, and there may be gap or a string or stenosed fibrotic canal, followed by a narrowed intestinal uh, part. So the atretic segment may develop uh, this intestinal obstruction, features of intestinal obstruction. So intestinal atresia is categorized into duodenal atresia, ileal atresia, jejunal atresia, colonic atresia, and rectal atresia. So in different areas, atresia may be uh, developed congenitally. Type: if it is partial atresia, that is present of wave or diaphragm or membrane that partially occlude the lumen of intestine. When the lumen of intestine is uh, partially occluded by a membrane or a diaphragm, that may hamper the luminal propagation of contents. And complete atresia is completely obstruct the lumen due to absence of a part or segment of intestine. This is some picture may show the intestinal atresia. This is proximal dilated intestine here, and also the narrow segment of intestine which is not well developed, and the lumen is not well developed, and occlusion are here. So the contents can't go here from the other area. There is gap, complete gap here. The intestine is not even formed, and there is gap, and the complete obstruction may be categorized. And this is another types of atresia. There is a B-shaped gap in the mesentery as well, and there is no intestine at the gap. So this is a severe form of atretic condition. This is another type, severe form of type, and this is another multiple atretic segment are here. There it is a B-formed gap here, B-shaped gap. And no, there is no uh, segment within this gap, within this gap. So these multiple segment are involved. So this is another severe form of atresia, may give rise to intestinal obstruction in the early neonatal age. Presenting feature, in case of intestinal obstruction, that is abdominal distension, vomiting, other associated feature that is feeding intolerance, failure to thrive, dehydration, septicemia, respiratory tract infection, anemia, jaundice, and other congenital anomalies. These are important features, that is abdominal distension and vomiting. You know about well about intestinal obstruction. I think you already gone through intestinal obstruction. These are important topics. Intestinal obstruction features are abdominal distension, vomiting, and sometimes pain, constipation. Others are chief features, and others associated features are these are, that is feeding intolerance, failure to thrive, dehydration, septicemia, respiratory tract infection, anemia, jaundice, and in case of children, that is other congenital anomalies. So this is end of my lecture. I will not go further. uh, you can go through the books about atresia, and you may prepare for next lecture class about intestinal atresia. So thank you very much.